Okay. I think that is everyone that's joined us today. Thank you very much, everyone, for introducing yourselves. Go ahead.
So again, this is our third part of our four-part series for our long-term care education. First one was polypharmacy, done by Leslie Baker, who's joining us today. And the last one was done by Dr. McCaleb, who we have joining us again today, which was done on delirium. Here at Project ECHO, we're trying to build our team of geriatric providers so that we can kind of give you that well-rounded view of how to take care of a geriatric patient. And so today, Kelly, who introduced herself, will maybe chiming in and kind of giving her 2 cents if there's anything that she feels that she may have to provide in her experience. And then Dr. Sharma will also be providing any insight she has. She also helps us lead this geriatric ECHO. And with that, initially, we always like to get started with clinic cases. I don't know if anybody has a patient with dementia that they have some questions that they want to share with the team so that we can kind of see how we work out, see how we can kind of work through, help you out. We'll give everybody a couple seconds to type something in the chat box or kind of raise your hand or speak up so that we can get a clinic case.
Yeah, feel free to write in the chat box. I'm sending something out in it right now so everybody can see where that is. Or take yourself off mute with the icon in the lower left corner. So yeah, any questions or patient cases you'd like to discuss, please feel free.
All right. So we'll kind of move on to the didactics for today. I titled it Dementia, a Syndrome, Not a Disease. And that's kind of just to help our thinking when it comes to thinking about dementia, because there's multiple reasons that people can have dementia. People can have Alzheimer's dementia. People can have Parkinson's dementia. People can have frontotemporal dementia. People can have vascular dementia. And even though those are all dementias, they're all very distinct diseases with distinct processes that kind of led to a specific way a patient is acting or is. And so just because we have kind of somebody here with us today, the way they got there makes a big difference on how we kind of assess them and on who they are and how we can treat them. And again, I guess to start off, I always like to let people know where we're going. So I'll start with the objectives. We have 4 today. I think in the top right corners, you'll see numbers as I kind of progress through the rest of the slides. And that'll tell you kind of what objective that slide is referring to. And so the first one is to improve our understanding of how we diagnose a dementia syndrome. Second one, understand the workup that should be expected to rule out the reversible causes of dementia. This part will look very similar to Dr. McCaleb's talk. Number 3 would be categorize different subtypes of dementia. We won't get into that very much. I just kind of want to give you a general idea of how I think about it as a clinician. Number 4, and this is what we'll spend a lot of our time on, is discuss methods to deal with the neurocognitive symptoms of dementia, which can be vast and very complex and very distressing, not only for patients, but for caregivers as well. So kind of always like to make sure we're on the same page, talking about the same thing before I start talking. And so almost all my talks, I start with definitions, making sure we all know what the definitions of the things we're talking about are. So the first one would be dementia. I define that today as a progressive syndrome characterized by acquired losses in cognition and emotional abilities that are severe enough to interfere with daily functioning and quality of life. And so, so I've already kind of used the word syndrome in my definition. And then at the very end, I kind of say these cognitive and emotional abilities are lost and they have to interfere with daily functioning of life for me to consider it a dementia. And so just because they're bothersome, if they're not affecting your ADLs or your IDLs, I may not give you that dementia diagnosis. To help you understand what a syndrome is, essentially a syndrome is a group of symptoms often seen together or a condition characterized by a set of symptoms seen together. And so essentially these set of symptoms can come from a variety of causes. We just know that we commonly see those symptoms together. One example of that might be an upper respiratory infection. That's kind of a word we use for a syndrome for somebody having either bacterial infection, and that there can be many bacteria that can cause that, or it could be a virus, and there could be many viruses that cause that. There could even be fungal ones that could cause that syndrome, again, much more rare, but that still falls into the syndrome of what we're seeing. And so dementia is a syndrome. All we are is kind of seeing the symptoms. Exactly why we're seeing those symptoms is usually up for debate. And then a disease, because we're talking about diseases, specific syndromes that are secondary to diseases. So a disease is a process with the specific signs and symptoms. It often has a known cause and known consequences. And so essentially, thing to point out is there are certain diseases that cause dementia syndromes. And that's kind of what I wanted to make sure we all got from that slide. Does anybody have any questions about the definitions? Something that makes sense, something that should be added? Okay. And so diagnosing dementia, these are kind of just two quick pearls when diagnosing dementia. It's not something based on a snippet in time. It's not that dad or mom or uncle or aunt was acting funny the other day and now they have dementia. It's something done through a thorough longitudinal history. You have to get a history of something to understand the syndrome, because changes that occur over days to weeks are not likely to be dementia. Usually these changes occur over months to years. And then kind of after you've kind of done those two things, you want to see what else could this be? Because I really don't want to be diagnosing anybody with dementia. I kind of want to find something else and say, oh, that's why they're acting funny. And so if somebody has an acute change, that kind of really makes us start thinking this might be a delirium, and then we'll go back to Dr. McCaleb and understand kind of what we did then. The other things that this could be are psychiatric illnesses. Psychosis or depression can also present as cognitive and emotional changes. And then again, we want to go over the reversible causes of dementia, which is kind of these are often medical diagnoses. And so when we're talking about the reversible causes of dementia, it's usually medications. What, you need to do a med review. Again, Dr. Baker, feel free to speak in for any common culprits of people that medications that may cause some mental status changes or cognitive or emotional changes. But essentially, any recent medication changes, any medications they've been on for a long time that nobody's kind of reevaluated. These are all things you want to think about before thinking about this is something that's going to get worse and not get better. And then the next few are kind of lab tests. You want to get a CBC, which rules out infection and anemia, which can present kind of the same way. You want to get a complete metabolic panel to rule out any electrolyte abnormalities, renal failure, hepatic failure. These are all things that can also make people make us think that somebody has dementia. We want to rule out an overactive or underactive thyroid, because those can also cause people to act differently. B12, that's a very complex, very integral vitamin in our body. And so we always like checking a B12 level, and if that's kind of low normal, we often check an MMA level, which is a methylmalonic acid level, to see if they have a functional B12 deficiency. We want to check an RPR, which helps us rule out neurosyphilis. With STDs back on the rise, even in older populations, this is something that we should definitely be having a very low threshold to check people for, because there are certain high-risk behaviors that make us think that people are higher risk for certain types of diseases that can cause cognitive changes. One of those is even HIV. And so HIV rarely, but can even present as a dementia for somebody that's not treated well. Again, very unlikely. Nowadays, this was much more likely 20, 30, 40 years ago, before we had better treatments for HIV. And then head imaging. Not everybody needs a head imaging. I almost get all my patients a head CT to rule it out. Sometimes I get this great history that's gone over 5 years with progressive decline, and I feel pretty comfortable not getting a head CT. But most people will get a head CT. Most practitioners will get an MRI. I think that is kind of up for debate whether all of those are appropriate, and a lot has to do with the culture rather than great medicine. And then there's also those other more esoteric tests, based on patient-specific risk factors. And again, these are kind of a lot more physician-oriented questions, or provider practice or healthcare provider-oriented questions. Because somebody that has a history of like a Roux-en-Y for a gastric bypass, they're at risk for copper deficiency, and copper deficiency can present as a dementia syndrome sometimes. And so those are the things that we have to think about when thinking about reversible causes of dementia. Is there anything else on this guy's list, or any questions that you all have?
Question.
Sure.
What about vitamin D? Has that been?
Oh, that's a great question. So vitamin D. So vitamin D has gone in and out of vogue. It's been on a pendulum as far as what it's helpful for. As far as cognitive issues, I'm not convinced, based on anything that I've read, that supplementing somebody with a low vitamin D level will improve their cognition. I think there's other reasons as a geriatrician that I make sure somebody's vitamin D level is normal. But just giving somebody vitamin D or a low vitamin D level causing cognitive issues, at this point, I do not think that those are linked. I do think that a geriatric patient can present with a geriatric syndrome, and a low vitamin D level may suggest some sort of neglect or malnourishment that may lead to something else that would cause dementia, like a B12 deficiency. But vitamin D deficiency by itself, without anything else to kind of grab onto it, I do not think at this point causes dementia. But I do think a healthy argument would be fair about that question. Any other thoughts in the audience or other parts of our? Yeah. Okay.
I was just going to say that I agree with replacing vitamin D levels, especially when they're at the deficiency level, like we're talking like the less than 10s and things like that. The only thing that I've seen, and it doesn't even really, it doesn't encompass cognition, is in some geriatric outpatients, I have seen what I could only put my finger on as a improved sense of well-being.
Yeah.
And so that was really the only thing that I could really latch onto it. And you know, who knows if that, like I said, that's a loose term that I just used. And so I don't personally think that cognition crosses into that, but you know, I agree with Dr. Labbe. I think that I haven't seen it have any impact on dementia syndromes, even when vitamin D levels are replaced.
Well, great question, though. Thank you. I've definitely seen that practiced.
So how often should B12 and vitamin D levels be checked?
Oh, that's a great question. So B12 levels should only be checked if you have a concern for a B12 deficiency. And so reasons that I would think somebody needs a B12 level checked is if they have a macrocytic anemia, if they have peripheral neuropathy changes, because B12 helps us with building of our nerves. The word we use is proprioception, would be the main neurological abnormality we see, which is essentially me being able to tell my hand is right here in space. When you don't have proprioception, if I close my eyes, I wouldn't be able to tell where my hand was. Only, but I can because of proprioception, which B12 helps with. And so those would be and then the third reason that I would check a B12 level is if I'm concerned about cognition. And I kind of check that level to rule out a B12 deficiency. Once I've checked it and it's low and I'm replacing it, I tend to check it one more time to make sure that what I'm giving them is actually getting into their body and the level is appropriately going up. But once I'm done with that, I don't. I probably wouldn't check too many more B12 levels unless the clinical scenario made me suggest that, hey, maybe something else is going on here. So ideally, you should only get 2 B12 levels. If your B12 level isn't sufficiently responding to the oral pill that you're giving them, that is there is some other things that we can think of at that point. But then we would just usually give you an intramuscular B12 shot. Vitamin D levels. So I don't know, to be honest with you. I think we check them too much at this point. I think that nobody should have a low vitamin D level if you're geriatrics and you're falling. But the reason I want you to have a normal vitamin D level isn't to decrease your risk for falls. The United States Preventive Task Force actually changed the recommendation within the last year, saying that for somebody with a normal vitamin D level, having them on a vitamin D pill does not decrease their risk for falls. But we do kind of want to make sure vitamin D levels are normal when somebody's at increased risk for bone fracture. And so again, I would check it once, start them on some supplementation, and then check it again to make sure it went up appropriately. But then when it was up appropriately, again, I would just check it clinically. I don't think that there's an indication for checking this with yearly blood work.
Dr. Sharma or Dr. Baker, did you have something to add?
The one thing I wanted to add for the B12 is if they're on long-term PPIs or metformin, those can both cause B12 deficiencies also.
Thank you. And anybody else want to comment on the B12 or vitamin D levels on how they do it in their practice? Okay. We all mostly train together, so we all probably practice pretty similarly. Was there any other questions, Troy, before I move on? Thank you. And so this is a busy slide. I threw this in here just kind of yesterday to make sure that we all knew what the validated tools were we used to diagnose dementia. As you can see here, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 different tools. And so there's plenty for us to choose from. And you can see there, they all take varying times to complete. These are kind of clinician tools. Our neuropsychologists who kind of are very kind of cognitive experts in dementia have much longer tests that they do. They assess all the different domains that have to do with our brain, essentially. All these tests test something like our memory, they test our executive function, they test our visuospatial orientation, Sometimes they check our abstract reasoning, our ability to attend, and each of these kind of has different validated tools. They all ask very similar questions, like making sure you're oriented to the time and date where you are, making sure you can say things forward and backwards. But essentially, they're all a little different, and depending on the population you're dealing with, really depends on the best tool for you. As you can see here, I highlighted 2 in green, which is the kind of 2 I wanted to point out to you. The MoCA test, which Dr. Michaela referred to earlier, which stands for the Montreal Cognitive Assessment. This one I use in clinic all the time. It has a sensitivity of essentially 100%. What that means is that I'm probably not going to miss any cases of dementia if I give the test. I'm probably going to overdiagnose. I'm probably going to get more people than I want to screening positive for dementia, because the specificity you can see is only about 87%. But if I follow that up with the 6 CIT or the cognitive impairment test, that might lead me to kind of get a better idea if this patient really has dementia. Most of these tests want you to rule out delirium and psychiatric diseases before you apply them. And so that's one caveat too, is that I see people using these tests for any patient they have that comes in with some cognitive issues. But I don't always see a delirium workup, or I don't always see a history of psychiatric diseases alongside with it. And as a geriatrician, those are very important to make sure that I'm kind of understanding this test in the right scenario, because these tests aren't fair to give to anybody that's sick or not in the right mind, because these tests can have lasting consequences on people's problem lists, which can have lasting consequences on how we treat them. Any questions about these tools, experiences that you have, questions? I kind of briefly going over it, but just kind of wanted to give you how I use them clinically. And then any of the other physicians or anybody else in the audience would like to give me their 2 cents on it, we'd be happy to hear it.
I have a question about it.
Sure.
Is MoCA the one where, you have them put like a dot inside the triangle and then you read them a story at the bottom? Jan was a so-and-so person, and they have to tell you who was Jan. Is that the one you're talking about? I can't remember.
Yeah, so that is the, I think that's the end of the slums, actually.
Is it?
So
Okay.
the slums is a St. Louis University mental status
That's the one I'm
exam.
confusing.
So that's the one done by the VA. That's a great test. I use that.
That's the one that I've only used.
Yep.
I mean,
That didn't even make it on my list.
didn't even make it. So, but I've noticed with the slums, actually, I have a problem with score. I mean, people get too high of scores, and I'm like, I don't really think you have. That's my biggest issue is like, and I write up assessments, but technically they got this score because they really couldn't read it back to me. And I mean, actually, I'm kind of challenged by it a little bit. You know what I mean? So like, it's a little challenging. I'm kind of like, is this tool,
Sure.
how valid is this?
That's a great point. And so this is, again, not evidence-based medicine. I'm just kind of giving you how I was taught. So all these tests kind of test the same things, but they don't test them the same way. Education level makes a big difference when using these tests. Slums, I would probably use for everybody in this audience, because I think we're all well educated, because it's a lot easier for me to pick up on issues, because you kind of have a higher functioning. The MoCA I use is really nice for people that maybe have only graduated high school or haven't graduated high school. It does a lot of pictures, a lot of less complex instructions. And so you can get a better idea. But again, that's not evidence-based, and that again is changing your patient population to meet your test, and that is not good medicine. And so looking at how these tools are validated in what populations is really important. And so for the slums, that was done with almost an exclusively VA population, which is adult white males. Not to say they didn't include females and people of other ethnicities, but there's a lot less of those in the veteran population. Good, great question. Thank you. Yeah. So far we've talked about, just to kind of quickly review, we've talked about dementia as a syndrome, and how that's a constellation of symptoms are seen together. We haven't necessarily talked about what those symptoms are yet. We will in a second. But then there's kind of different ways that these syndromes pop up, and a lot of that is based on their disease process. And so the kind of linear dementia syndrome, which kind of, I can thank Dr. Michaela for kind of opening my eyes to thinking about it this way, so I appreciate it, Dr. Michaela, is thinking about, there's a natural progression to all diseases, and Alzheimer's has a really, what we think is a characteristic natural progression for the disease, just based on the pathophysiology of how it kind of affects the hippocampus, and then how all of the neurofibrillary tangles and the tau plaques deposit in the brain and cause issues in a kind of stepwise pattern. Reisberg came up with this nice scale, the functional assessment of staging, the FAST scale, which really kind of shows you what a nice linear dementia is. Unfortunately, that is not most of our, that won't be most of the dementias that you end up seeing clinically, because most dementias end up being mixed. And so just for some kind of quick ideas of kind of how to think about our patients, for all comers 65 and older, 6 to 8% will get a dementia syndrome, and 2/3 of those will be Alzheimer's, which is most of them, but then a big portion of those are mixed as well, and so they kind of include vascular dementia and frontal temporal dementia. Vascular dementia, often they decline in a stepwise process, so essentially people often have strokes, and so you see these specific changes after each stroke that result in cognition changes, and families can often tell you, yeah, it was after this hospital stay, or after you got a stroke that I noticed this issue, and then often it'll be multiple different stories similar to that. And then there's frontotemporal dementia, which is also another nonlinear dementia syndrome, meaning that depending on what part of the brain that is kind of being affected, is kind of depends on the symptoms that you'll see. Frontotemporal dementia often has to do issues with executive dysfunction and disinhibition. What we mean by that is planning and stopping yourself, essentially thinking before you talk. And so for all of those that had to learn that, like me, I imagine I might get some sort of frontotemporal dementia syndrome in the future. So that's something to watch out for. And then all of these, depending on the scale you use, I said Alzheimer's, you should probably only use the FAST scale for Alzheimer's type dementia. But there are other types of dementia scales that you can use for these nonlinear dementias. One of them is the Dementia Severity Rating Scale. It's kind of long and complex, and a family member can even fill it out. And a little out of the scope of today, but I just wanted to make sure I mentioned it, just so you know that there are different scales depending on the type of dementia that are validated differently. And so these would be what I would consider maybe the more common types of dementia, maybe not so much frontotemporal, but Alzheimer's and vascular dementia are the two most common. There's more uncommon diseases. There's a rapidly progressive dementia, which is kind of a prion disease. Mad cow disease is kind of one that kind of comes to mind. We actually ended up taking care of one within the last year. I think Dr. Michaela helped, Kelly helped, and I was able to help a little bit too. And so that was a very interesting case of somebody that had Creutzfeldt-Jakob disease. Normal pressure hydrocephalus, which is also something that can present more quickly, can present as a dementia syndrome. And then there's this kind of Parkinsonian dementias. And so Parkinsonian dementias, anytime kind of hear the word Parkinson's, Parkinson's is a syndrome also. There's a Parkinson's disease, but that's kind of based on the natural history, which kind of takes 5 to 10 years, maybe even longer, for us to figure out exactly what somebody's disease has. Often we kind of infer that somebody has something based on what they're initially presenting with. The kind of 4 Parkinsonian potential for dementias are Lewy body, which often presents as visual hallucinations. A Parkinsonian's dementia, often that's somebody with Parkinson's disease that has kind of progressed into their disease process for multiple years and is then starting to have some cognitive issues. There's one called progressive supranuclear palsy. There's a supranuclear nucleus in your brain, and essentially that goes bad. And so then it kind of has some suggestive symptoms that are all Parkinsonian, but also some characteristic eye changes as well. And there's corticobasal degeneration, and that's kind of your cerebellum. And so all of that kind of stuff can cause issues with movement disorders, which all look like Parkinson's. And again, any issues with your brain can also cause cognitive issues, which is why we kind of lump this all into a syndrome rather than just a specific disease process. And that was just, again, to give you the idea of the common types of dementia, the uncommon types of dementia, and how we think about them linear versus unlinear, and that depends on how they're kind of affecting the brain. And so this is the first part of my lecture where I kind of go over just kind of dementia syndrome in general, some basic ideas on how to rule it out, and kind of how to categorize it. The next thing I'm going to move on to is kind of the meat of the subject. And I do see we're running out of time, so I want to move on. But it's kind of has to do with the neuropsychiatric symptoms of dementia. Essentially, it's a guide on how to communicate with those who aren't able to. And so throughout the slides, you'll see kind of see NPS, and so that stands for neuropsychiatric symptoms of dementia. We're going to start out with a case today. We have a 99-year-old male with a past medical history of coronary artery disease, benign prostatic hypertrophy, chronic constipation, chronic pain, and monitored severe dementia syndrome. Presents to your office with a daughter who moved in with him 2 months ago. Chief complaint is medication review. So after you ask how you can help with the patient today, the daughter breaks down in your office, and as she tells you the trials and tribulations she has had over the last 2 months. As you empathetically listen to the daughter, it seems that her complaints revolve around her father refusing the care she is trying to provide. She gives you repetitive examples of how her father is not taking his medications, not eating, and not sleeping well. So, based on what little we know, what kind of questions would we want to ask? Anybody? I'll put Dr. Michaela, what kind of question would you want to ask?
First thing I'd want to do is start with duration of time that this has been occurring over.
Good, okay. Duration. Any other questions you all want to ask?
I'd say what's going on in the environment. Is this a new change? Did he move in with the daughter? What's happening that has been a change from what was the normal routine prior to this?
Good, good, yeah. I might even ask why she moved in, you know, because often that is very telling on why somebody moves in. And so you can tell, I guess I'm taken also by the silence that people may not be exactly sure on how to approach a patient like this, because this is very hard. You know, it's just kind of somebody coming in you with emotional responses, and you know, we're supposed to emotionally respond to them, but at the same time, we need to have kind of an algorithmic way that we're approaching the problem. And so I was hoping we would get more questions, but these were the things that came up onto my mind first, especially with this history of constipation. You know, when was the last time he pooped? When people haven't pooped, they get angry. You know, how often is he actually taking his medications? What medications is he taking? That kind of brings up the brown bag test, which goes back to our first lecture with polypharmacy, making sure we all know all the medications he's trying to give the patient. Are there issues with pain? And then kind of what's his functional status? What are specific IEDL or ADL deficits? Because kind of those help us. And as you can tell, these are kind of a shotgun approach to questioning. You know, hopefully we'll get a good answer for it. But I kind of want to know, is there a better way? Is there a better way to kind of approach you know, a patient and a caregiver like this? And so essentially what I'm hoping to give us is a structured format to approach this issue. Does anybody else out there have a structured format that they use sometimes when dealing with issues like this?
I mean, just
Yeah.
I guess to know the severity of the situation. I mean, how much are they eating and drinking? I mean, I want to know, like, you know, nuts and bolts of how far into the hole are we right now? You know, I mean, that's kind of where I guess I structure it the most. Is like, how much is this person taking in or putting out? I guess at this point. So yeah, like, I mean, I guess the way of putting it is, I think, well, how close? And I come from a hospice background, so I'm thinking, like, how close to death are we getting here? How bad is the situation? And then I kind of back it up from there. Okay, yeah, he's sleeping about 6 hours a night. Okay, well, how much is he eating? Well, he went from eating, you know, 3 meals a day 2 days ago, and he's had, you know, half a boost today. That's a huge, significant change. I want to know how much change over how much time.
Perfect. So. I love that. Yeah, and I think that's perfect. I think that's great. He's 99 years old, right?
Yeah.
You know, he's lived longer than he's going to live.
Yeah.
And so I think making sure people have good quality of life instead of us trying to give those medications that they have less effect. So thank you. Appreciate that. Anything else you all have out there?
I think it's important too to really choose your battles when it comes to dementia. So what's the most bothersome part of this case? Is it more important that he's sleeping, obviously eating, or should we be battling the medication issue? So really, again, identifying the goals of care in this situation would be important.
Perfect. Yeah. And so I think those are two great examples. Thank you. I think the having this in kind of a structured way is important. And the difficult part about this is that we're dealing with the syndrome, right, which are a common constellation of symptoms seen together, but not all the symptoms aren't always there. Sometimes they're absent, sometimes they're gone. And so it's really hard to have that kind of characteristic way to approach something when it's not always the same way when it gets presented to you. And so essentially, the first thing to do when we're diagnosing any issues is we got to put a name to it. Like I talked about with the definitions when I first started, neuropsychiatric symptoms of dementia all have, there's certain words that we can use that are helpful. Often I see words like agitation. Patient was agitated. What does agitated mean? One time I went into to go assess a patient that was agitated. You know, they said they were trying to get out of bed, trying to run out of the room, you know, trying to go away, and so he got a bunch of Haldol, and then he was sleeping. And then so I went in there, I'm like, so why was he trying to run away? What was he trying to do? Long story short, the gentleman was hallucinating. You know, he thought there were bats in the rooms, and he was trying to run away from the bats. And so just because somebody's agitated and trying to run away, you know, because we're just treating that running away, we have a big chance of missing the actual symptom that may have been initially causing that behavior. And so that's just kind of one example. And so the ones we have here are aggression, agitation, depression, anxiety, delusions. Delusions are a false fixed belief. Hallucinations. Hallucinations are the visual or auditory perception of things that aren't there according to other people. Apathy, disinhibition, and wandering. And so whenever you guys are trying to describe behavior to your providers, I always ask for one of these to be described with, because it kind of helps me understand what exactly I'm dealing with. And so rather than saying somebody's just aggressive or agitated, you kind of go into exactly why. And so using this mnemonic, I guess we'll get there next. Sorry, one slide ahead. And so neuropsychiatric symptoms of dementia, essentially, like I mentioned earlier, 6 to 8% of patients 65 and older will get dementia, but 98% of those 6 to 8% of people are going to have some sort of symptom that have to do with their behavior. And so this is something that we all need to be very familiar with and know how to treat. The reasons that people have these symptoms are because of unmet needs, environmental overload, interactions of the individual and caregiver, and environmental factors. And so all those things have kind of already been mentioned by our team here, but just kind of wanted to make sure those are written down as well. So there was this nice article that came out a few years ago using this mnemonic called D.I.C.E, which kind of helps us treat patients with neuropsychiatric symptoms of dementia. The D stands for describe, investigate, create, and evaluate. It's evidence-formed, not evidence-based medicine. So essentially, when you're describing something, you want to have the caregiver play back the neuropsychiatric symptom of dementia as if in a movie. You want to tell you play-by-play, exactly what happened, what was going on before, what were you doing when the behavior started, how did you react to the behavior, and then how did you deal with the behavior. You always want to ask the patient what they thought as well, unless the patient has severe dementia. Their perspective, which is kind of how I figured out this other patient was hallucinating, was the only real way that I was able to figure that out, is you actually have to talk to the patient and see what their perception is of it. And then you need to determine the most distressing part. Things that don't bother people, that people aren't going to talk to you about. And so you need to see, why is this bothering you, or why is this bothering the patient? And making sure you kind of set appropriate expectations with those as well will be important. So investigate, similar to workup for delirium. We are running a little short on time, so I will kind of go over this quickly, because a lot of this will kind of be on the next page, because I want to essentially have you guys use a checklist when you're dealing with patients like this. Essentially, you want to make sure you elicit the perspectives of the caregiver, elicit the perspective of the patient. You want to review the medical history, review the psychiatric history, make sure there's no sensory impairments, and that includes hearing, vision, making sure they can hear you appropriately. Because if you didn't hear my instructions, how am I gonna, how are you gonna do them? If you can't see me, maybe I'm getting confused. Maybe I think you're my mom or something. And then making sure they're defecating well and urinating well are also important, because those are also sensory changes. Making sure there's not over or under treatment of pain. And then this is kind of where we get for those of us that are nurses, this is where it kind of can be most helpful for the physicians. But this is definitely a higher practitioner level job. You want to assess for a new medical condition. Is this patient infected? Is this a new episode of gout? Or you want to assess for a worsening of a chronic medical condition, a CHF, depression. Making sure they're sleeping well is important, and understanding how they were sleeping at home is probably more important than making sure how they were sleeping well. It's really hard to change somebody's sleeping habits that's been sleeping the same way for 80 or 90 years. You want to do a medication review. Getting your pharmacist involved with that will be helpful. And then at the very end, you always want to ask, can we modify our approach to the situation that resulted in this neuropsychiatric symptom of dementia? And so once you describe it, you investigate the cause, you want to create a plan. You want to make sure you include the patient and the caregiver in your plan. The more minds, the better. Utilize your interdisciplinary team. And then you want to eliminate aggravating environments. Often it's only during bath time or going into a certain room. Maybe the patient doesn't like being in this room because it reminds him of his wife that passed away a year ago. Sometimes there's certain sounds in our veteran population. Often we have to be very considerate of certain sounds and loud noises, because they can even set off some sort of PTSD type reaction. And so those are kind of all play big roles. And then again, I'm a big checklist guy. You should have a checklist for when you're creating your plan. And this is kind of not necessarily, this is something you can just look at as you're creating it. 3 big things there is enhanced communication strategies. Don't forget you're communicating, the provider's communicating with the patient's communicating with the provider, and the patient and the caregiver are also communicating. And often that last one is where you have to do the most work, is kind of is teaching the caregiver how to interact with the patient. Monitor your tone of voice when you're kind of having these conversations. Health literacy is a big deal. Again, making sure patients understand why the treatment plan is in place is very important. You want to simplify tasks. You want to provide education and support. Also, again, this kind of gets involved with, things that work well somewhere else. You kind of want to utilize them rather than kind of reinventing the wheel at your home, because a lot of this can be a lot of work. And so understanding what resources you have in the community is very important. Environmental strategies, remove clutter, minimize sensory overload, understanding what their old hobbies and interests were, getting them to do that. Home safety, equipment are all important. And then the most important thing is making sure you schedule follow-up. The last thing you can do is kind of set a nice plan in place, but never understand if it works. Oh, thank you. And so then you want to evaluate. You want to discuss why certain interventions were not implemented, discuss whether the interventions that were implemented were done correctly, and if they were effective. And then you kind of want to assess the reaction to the intervention, whether it was positive or negative. And then you want to educate that the symptoms will change or fluctuate over time. Dementia is a progressive syndrome that changes over time. And just because something worked a year ago doesn't mean it'll work the next year. And so this is something that I often go through sometimes on a multi-daily basis with one patient. And so it's a very effective tool, and it gives the team a great way to kind of approach the patient so that we feel like we're making progress. And again, just to quickly review, I know that was very quick, but I wanted to make sure I ended on time. The D.I.C.E mnemonic is an evidence-based, I guess it's not evidence-based medicine, it's evidence-informed, it's informed. So you want to get a play-by-play, you want to figure out why they could be acting this way, you want to make sure you include the caregiver, the patient, and the IDT in a plan, and then you want to make sure you evaluate why or why not the intervention did not work. And so the goals on so why are we going to take all this effort to do this big D.I.C.E mnemonic, is that if we can hopefully modify behaviors, we are hopeful that we can modify the disease course and minimize complications, risks, and the natural history of the neuropsychiatric symptoms of dementia. This will also improve the underuse of conservative measures. Conservative measures have good evidence with respect to improving quality of life for both patient and caregivers. We often use medications in lieu of conservative measures that often have poor or no evidence of efficacy. And so that's kind of why I wanted to spend so much time on this D.I.C.E mnemonic today. I know at other places they use other types of mnemonics. I was hoping Kelly could talk about the STAR-VA mnemonic a little bit. But I think that this is my last slide for the most part. But I want to give an opportunity for questions.
So we did have a question from earlier in the presentation. What are the signs that Namenda and Aricept have reached the full benefit, since it is only for the beginning signs of dementia?
So thank you for the question. The beginning signs of dementia. I guess where did you learn that about that those were the appropriate medications for the beginning signs of dementia?
Kathy, could you share that, please? And actually, I think I might just take you off mute so you can speak to that. Go ahead.
I have a new protected person that I just got, and she was prescribed Namenda and Aricept, and she has, I wouldn't say, probably mild dementia. So I'm wondering, I'm thinking that that's why they prescribed it to her, but I'm not real sure if she should keep taking that, because she's in a controlled facility right now, and she don't want to take it because she says she don't like how it makes her feel.
Yeah, so thank you for sharing that with me. That's very helpful. These medications the Namenda and donepezil, they don't alter the progression of the dementia syndrome. They don't help you live longer. They may be some small benefit with respect to decreasing the decline in patients that are about to lose their ADL status or IADL status, meaning they're having issues managing independently in the environment. And so they may help you manage a little longer in the environment, but once somebody is already institutionalized, often those things can be provided for them. And so that benefit is gone. And so that is the main benefit that I would start those medications for. And so I would tend to agree with you that if these medications aren't necessarily making the patient, they're making her feel funny and she doesn't like to take them, and there's not necessarily clinical benefit, that there's not an indication for those medications at this point.
Okay, because she's able to do her ADLs and functions quite well in a structured environment. So that's good to know.
Yeah. Yeah. Anybody else have some thoughts on that great question?
I think just that the studies that were used, that the FDA predicated their approval for the use of these medications, all had institutionalization, as Dr. Libby is saying, as their endpoint. So once you're already institutionalized, it's redundant to initiate these medications at that point. Now, to Dr. Sharma's point earlier, if you've reached a point where you're negotiating some of the neuropsychiatric symptoms, there may be some small benefit to that. I certainly don't use that myself, but it is described in the literature. Then that might be a time when you could consider starting one or both of these medications. But I would, as I said, my point is, if you've reached the endpoint of institutionalization, you're outside the window of how the medications were studied.
Any other questions out there before we finish up for the day?
Kelly, anything you want to add with respect to?
I could briefly go over the ABC model that the VA uses if there's time.
Yeah, I mean, I think it's important for other people to learn more models. I know we're already over, and so anybody that needs to leave, we do appreciate your time, but don't want to hold you here, but we also wanted to provide more information since it is pertinent.
Yeah, so the VA uses this ABC model, which is very similar to the D.I.C.E model, and it focuses on identifying that disruptive behavior, or really identifying what the priority behavior is that we're trying to change. And then we go in the A in this model is the activator, so identifying exactly what is causing these behaviors. And a lot of times what we focus on is perhaps it's the approach that nursing staff is using. It may be the environment that the patient is in, really getting down and identifying what is triggering these behaviors, because those are all things that we can really change. We are not going to be able to change a whole lot when it comes to the patient with dementia, but we can certainly change how we're approaching them. We can change the environment. We can do things to make sure that we're addressing their individual needs. We, again, use that as how we react to them. So I can give an example of one veteran who was having a lot of behavioral disturbances. We were having to call behavioral codes to intervene because he was getting physically aggressive. In that situation, he had been trying to go into the nursing station, getting papers off of the nursing desks, and the nurses reacted to him by saying, no, you can't take that, or you need to get out of there. And by them saying, no, stop, don't do that, or trying to take things from him, that really was his activator. It set him off. And in his mind, he thought he was the boss, and he should be the one holding all the papers. And so that's where we really provide a lot of education to the nurses and say, you know, what's really the harm in him holding these papers, or perhaps we can provide him with his own. So our intervention for that is also aligning with the STAR VA ABC model, is identifying their pleasant events. And so a pleasant event for this individual was the fact that he likes to be a boss, he likes to feel in charge, he likes to hold those set of papers. So we gave him his own binder with business plans, with inventory counts, and that was his binder that he could hold. And nursing then changed their approach. Instead of taking things away, they would give him different worksheets to do. They would consult him as a boss, and his behaviors immediately improved. Over time, we've actually been able to wean him completely off of antipsychotics. So it's been a very successful model for a lot of our veterans here at the VA, and this is something that they use nationwide. And I'm sure that the specific ABC card is something that you could pull up, but it's a helpful tool to have a hands-on little resource for nurses to be able to look at quickly. It's a one-page tool that we have all of our interventions listed that they can reference in order to learn more about the veteran, and then also to learn how they should be approaching that individual. Thank you.
Thank you, Kelly. That was awesome. Great example. Any other questions or questions before we say goodbye? Well, don't forget, we have one more lecture in this series. It's in about a month. We'll be doing with competence versus capacity.
Yep, October 17th, competence versus capacity, hearing from Kelly McMillan.
Yeah, and we are thinking about doing a bonus lecture for us. We'll see if you guys wouldn't mind, for those of you that are still here, letting us know if that would be something you're interested in. We can get that going for November. Probably won't be the third Wednesday because of Thanksgiving, but we'll choose another one. So thank you, everybody. We do appreciate your time. Hope it was helpful.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.